Psychiatry, and equally honored to serve as your MC for today's event. Yeah, that's good. Thank you, John. Research Day is always a very special day in the department for a lot of reasons. So it's the big event that brings us all together, whether you're a clinician or a researcher or you have a foot in between. If you're a trainee, a staff member, a faculty member, you're part of our department family. So it's a really special event. And it's also a time of year that we're thinking about our rising stars who are moving on to bigger and better things that we're so proud of. And for me, this Research Day season has been a very emotional one because my daughter graduated from college 2 weeks ago. Thank you. So as you may sympathize with her, even if you don't know her, that she's my only child and I'm a perfectionist researcher. So it's been a hellacious couple months for her. So I've researched Pinterest, every detail on the venue, all the information, and spent months picking out the perfect, white summer sundress for her to wear. And she's a tiny thing. She's about 5 feet on a good day with good hair, and she wears a size 3.5 shoe. So this is no small thing. So anyway, so we did all this planning and everything. And so I just wanted to share with you, this is the text exchange between my daughter and I, the couple days leading to the event. Monday. So the event is Friday. Monday. Little one, that's my nickname for her, don't tell her. Little one, Dad checked the weather, slightly concerning. Sounds like it may be a bit cool and perhaps some rain during the day. Isabel, fine. Wednesday. Isabel, good news. Rain will happen all day, and now they're projecting 55 degrees. So perhaps white sundress not the best idea. Isabel, non-negotiable. Thursday, rethinking a few things. Won't fight you on white dress, but am concerned about 3-inch heels in rain and muckety muck in the grass. Isabel, non-negotiable. Friday morning, Isabel, I hate to even bring this up, but we are bringing 3 grandparents in their 80s to your event. It's freezing cold and it's pouring raining, and there's no place to drop them off at the venue. So I will be taking them on a 15-minute journey on uneven path. So just thinking, not saying anything, but thinking. Isabel, non-negotiable. Grandma will be fine. She's from Puerto Rico. Friday comes, and here's our lovely family. That my dear sister is the only reason we had a photo that day, because it looks pleasant, but it's pouring raining, it's crazy cold, and there's 1,000 people there. So I looked at this picture the last few nights, and I was really reflecting on what it all really means. And I think it's a good metaphor for this slightly atypical year that we've had as a research and academic community. And at the end of the day, the truth is you have no control over your environment. And there's going to be a lot of hiccups, a lot of problems in the way. And also, I learned is that if your goal is to get an award or a prize, you're not going to feel that satisfied when you show up in this muckety muck. The goal is not the award or the prize. The goal is the journey of learning new skills and becoming a better person in whatever field or whatever vocation that you have. And finally, I learned 2 other things. One is it's really important to smile. But most of all, it's important to bring good people with you on the journey. And so I'd like to invite everyone who has presented at the research poster session prior to coming down here to please stand. Please stand. There's 65 of you. You got to stand. Stay standing, stay standing, stay standing. This is your moment. Who cares if it's raining? Now I'd like to invite your mentors who are here to also stand and get a round of applause. And while you're standing, I'll read the final text. So Friday night at midnight, I text my daughter, we're super proud of you. And she goes, really? And I said, non-negotiable. So please have a seat. And I'm very delighted to invite our wonderful chair, Dr. Jill Rockbeisel, to share a few off-the-cuff remarks about her experience on the poster session. I know Jill locks this in her schedule in like October every year. So she's a big fan of the poster session, so we will invite her to say a few words.
Thank you, Gloria. Really appreciate that. So just a few words, because this is Gloria and everyone else in the room's show today. But I would also like to welcome everyone. Can everyone hear me? Can you hear way in the back? Yeah? Great. Okay. Want to welcome everyone to our 2026 poster session. It is thrilling to be just immersed in the excitement, the thinking, the scientific thinking, and the success of everyone that's involved in today. It's just wonderful. It is a true celebration, and Gloria and I didn't compare notes, so of all of our rising stars and our outstanding trainees, our staff, everyone, it's a true celebration. It's a reflection of the potential that our individuals that we work with every day and mentor have. And it seems infinite. It's also, though, everyone's success, because the success of today, of all of those posters and all of that work, lies heavily on the shoulders of the senior mentors. If you don't have a good mentor, it's difficult to keep moving forward. And so the senior mentors who brought folks along and helped them with everything that they've accomplished is clutch to this whole process. So truly a successful celebration for everyone. So I just want to thank everyone that has participated. First and foremost, Gloria's team. Gloria, with special shout out to Sarah Clark, it's Austin, Kelly McNett, who's somewhere behind the scenes writing all over the place, to all the poster presenters, the interns, the residents, all the trainees, and I have high schoolers that were also, again, speaks to the mentorship that we have in this room, that we have high schoolers involved in our poster session. So fantastic, and I will hand it back to Gloria to take us to the next step.
Thank you so much. I wanted to first recognize, before we move on to the awards, I wanted to first recognize our amazing research steering committee. As the research vice chair of the department, I'm really honored to even be associated with this amazing brain trust of folks who really come together and really try to think about department-wide research initiatives. So we're very grateful for their service to the department and to the school. Yeah. So just to orient you to the plan for today, since it's a little bit longer than our typical grand rounds, but we will end on time, I promise. So first, we're going to go over some awards. This is a lot of fun for us because nobody really knows in the audience if they're getting an award. These are all surprises. And then we're very honored to have Dr. Pan Hung as our keynote speaker today, talking about future directions in rural health research. Somewhere along the way, there's a bit of a surprise item on the agenda. So this is something we just started in the last year or two, and it's based on the concept, if we're going to talk about high-level science, we need to include the arts in the conversation. So what we started is kind of a new tradition. I haven't talked to Jill about this yet, so hopefully it's fine. But we invite somebody who's been a recent graduate in an arts program. So they have to have the credentials. And we tell them about the theme, and they can create an original expression that lasts for 5 minutes. It will happen at some point. You'll know it when it's happening. I have no control over content, but I protect my job by only recruiting people who are related to either a staff member or a faculty member in the department. So I know who to blame if there's a problem. Okay. So I'd like to start first and invite to the podium Dr. Sarah Clark. Sarah is one of those Renaissance people that she spends a lot of time with mice doing high-level basic science research. And then she somehow miraculously can talk to not just mice, but us clinicians. And she teaches clinicians how to get involved in research. So she's very involved in the research training here in the department. And I'm going to ask her to share with us the award winners for the Dr. Pat McMahon Poster Award. Pat McMahon was a beloved colleague who spent his career at the Maryland Psychiatric Research Center and really supported so many studies it'd be impossible to count. So in Dr. McMahon's memory, we named the award after them, and so it's a huge honor to have an award named after Dr. McMahon. So I'm going to turn to Dr. Clark, and I will say that since we didn't know who was getting this award until a few minutes ago, there's not a poster or a certificate or anything yet, but we have a little prize we're going to give you, and it's sort of in the theme of have a little fun this summer because you work hard. Can I invite the chair to come up and also Dr. Anique Forrester, the director of our Community Engagement Committee. And I'll ask you to stand here. And when the poster awardees are announced, please all come up and stay up for a photo.
All right, welcome everybody. I'm not going to beat around the bush too much. You've already heard all of the accolades and everything, and I would just be repeating much of what has already been said. But kudos to all of you. Thank you to all of my judges. We had an amazing turnout this year of judges, and we would not have been able to take on the scope and breadth of posters that we had this year without you. So shout out to you guys. We had 3 basic poster categories this year that everybody fell into. The first was the quality improvement posters. These are projects that are really geared towards finding ways to improve not only, potential interactions and things for our patients, but also for our residents, for the community, and rating different programs and how they improve. And then we had basic and clinical research posters. Those are the rats and mice and humans to some extent. I'll allow that. And then we have the observational poster category, which is more of those studies that are the hypothesis-driven studies, the case studies, the reviews, the survey work that people sometimes do just to kind of build up our knowledge base so that we can generate those hypotheses and test them later. So for the winner of the QI poster, it was Michaela Petolio or Petoilo. I'm so sorry. I am murdering your name. And Michaela, if you're here, can you please come forward? Now you're on the spot. You had no idea. That's how we like to do it around here.
Go ahead.
All right. And then for our observational posters, the winner is Brian Stiles. And then in the basic and clinical category, it is Benita Vedic. Focus. You all did an exceptionally well job. It was a very tough year for judging this year, one of the toughest that I've been involved in so far. So you really do all deserve a round of applause.
You guys stand.
Okay.
For the next award, I'm pleased to announce the Dana Foundation Award. This is a very special award for a couple reasons. One is that the application requires the applicant to come up with a plan to disseminate their research findings to both a consumer as well as an academic audience. And the project is to address the unmet need of in our community. And I'm pleased to announce the winner of this year's Etta and Meyer Dana Foundation Award is Dr. Nicholas Christian. It's the first time we've met in person. I've only met him in Zoom, so nice to meet you. Please. The next award also has some very special things about it. The most special is that we're very pleased to have the foundation representative join us as Research Day. And I think, honestly, she's an honorary microbiologist at this point because she's seen so many posters. Can I invite Miss Kitty Simpson to come forward? Thank you very much. The Dr. Betty Hughes Foundation is named after Dr. Betty Hughes, who integrated three important things way before it was cool, and that is child development, mental health, and public policy. So what she did impacted at all three different levels. And we're very honored to invite back to the front Dr. Sarah Clark, who is this year's winner. And since you've heard me do a lot of talking, I'm going to invite the esteemed Dr. Deanna Kelly to come forward. Dr. Kelly is the director of the Maryland Psychiatric Research Center and was just named the Distinguished Professor at University of Maryland. That's the highest honor. We're running out of awards to nominate Dee for, but a big round of applause for Dee for that honor. Dee will be announcing the name of the Jarborough Award recipient and a few words.
Great. Thank you so much, Gloria. Glad to see everybody here today. Okay, so obviously since I'm up here, this is an awardee from the Maryland Psychiatric Research Center this year. I'm very excited to talk about someone who does translational science, is a clinician scientist themselves. This person is a psychologist and an investigator, so sees patients regularly but participates in research, has a line of research looking at anhedonia, negative symptoms, motivation, and some of the areas that are under-treated and have no treatment targets right now, or not treatment targets, but no treatments available. So for the treatment of people with schizophrenia. This person not only has an awesome line of research, published 35 papers to date, 5 book chapters, forgetting many things, but also has developed a psychology internship program with UMBC, so is active in being able to train the next generation of people. This person has also been put into a leadership position at MPRC and has been able to work on organizing our clinics and our clinic move to start a brand new joint co-located clinic, and has taken on a major leadership position. In doing so, has been named part of the Dean's Leadership Committee and is now working on a couple of leadership positions at the university. So I went over a lot of details, but it's Dr. Adam Culbreth. So congratulations. Hi. In addition to all those qualities, he is likable, funny, and we love his Southern charm. So come over here.
All right. Now that the Oscars are done, we wanted to give a few minutes to reflect before going to our key.
Chopping down a forest not a necessity, but to why destroy all of them? Russian forests are being decimated. Billions of trees perish. Animals and birds have to look for a new place to live. Rivers recede. Wonderful. Sacred landscape is disappearing. And all account for people like you who can't bend down, pick their fuel up from the ground. You have to be a barbarian to take that kind of beauty and burn it up in your stove. Man has been blessed with reason and creativity, but instead of progressing, he only knows how to ruin. There are fewer and fewer forests. Rivers are drying up. Wildlife is being displaced. The climate is changing. Every day, the land becomes less fertile and more disgraceful. Now look here. This is a map of our district 25 years ago. Now just a third of the district is covered by forests. There are no goats anymore. There are just a few elk left. The green and the blue are faded, and so on. Now, we come to our district at present. Green is scattered now. It only exists in patches. The elk are gone. The swans are gone. No more wood grouse, no more little homesteads or monasteries. This is a map of undeniable degradation. A degradation that will take about 10 to 15 more years to complete. Now, I might say that this is progress. This is civilization, that the old has to make space for the new. And I would understand that argument if in place of these forests there were paved roads, or schools, or train tracks, anything that can make society healthier, or wealthier, or smarter. But there's nothing of the kind. And we still have the same swamps and passable roads, poverty, typhus, and diphtheria than ever. Now, this degradation is the result of man's pointless battle with existence. Degradation comes from ignorance, from a total lack of self-awareness. Freezing, hungry, sick people, desperate to survive, relieve their hunger, provide warmth to their children, be thrown in. Everything is being destroyed. And nobody thinks about the day after tomorrow. I mean, look, the land is ruined. Nothing given back in return. I can tell from your expression that you don't find this interesting. You know, you're giving me an ironic look. And you know what? Like I may be crazy, but when I walk through a forest that I saved, when I hear the sound of wind rustling through the young trees, when I realize that I have my own little control over the climate from the trees that I've planted, and after thousands of years, if one person is happier because of it, well then, I can't tell you what I get when I plant a birch tree and I see it grow, sprout leaves, I mean, the look of pride. Pride. But then again, I think it's time for me to go. Maybe I am just crazy. Goodbye.
That was Tudor Rico, who's a graduate of the NYU theater school. And when he sent me the text, I said, oh, a lot of environmental, political stuff in here. When was this written? In the last couple of years? He goes, Gloria, this is a play from Chekhov. So really the timelessness of the struggles and thinking about our connection with the land. Now that you've had a little pause to clear the brain, I'm delighted to introduce our honored keynote speaker for today. Dave, we can switch over to the slides. We don't have to do, I'll do the last one at the end. Dr. Pei-Yin Hung. I met Dr. Hung through the office that keeps track of all the rural health research and has an amazing repository of it. And it really helps to support dissemination of especially federally funded work around rural health research. And I cold called somebody out of the blue, the director of this program, and I said, I need somebody who has to do something quite impossible, which is talk about an important topic, but I'm only going to give her about 20 minutes, maybe 30, because we want this to be a conceptual talk, and we have a mixed audience of clinicians, researchers, non-academic folks, and we want to make sure that everyone connects with the materials. And without a pause, number one on my list to reach out to, he gave me a list of 4 people, and I was delighted I didn't have to go past to number 2, Dr. Pei-Yin Hung. Dr. Hung began her academic and scholarly training in Taiwan at the Zhongshan, thank you, Medical University. And then she achieved a certificate from the University of Washington School of Public Health, as well as her master's in public health from Emory University, and then her PhD at University of Minnesota School of Public Health. There's so many things I could talk about from her illustrious CV, but I want to zero in on one thing in particular, and that is in the last year, she received 3 really incredible honors. The first honor would be honor enough, Outstanding Researcher of the Year from the National Health Association. Huge honor, huge recognition, national award. She also, at the same year, received the award Student Career Influencer from the University of South Carolina Career Center. So I thought this is the person to bring for Research Day when we're thinking about our rising stars, excellent in science and excellence in teaching, training, mentoring. But then she blows it out of the water with the award number 3, which I've never heard of, but so impressed by. And that is she was achieved as one of the Fierce 50 honorees for health equity. So we know it's not enough to take your talents to publish in a journal or to train and mentors others. It's so important to be an advocate. And that is probably the one theme that unites us all as researchers, clinicians, our staff, our trainees. So without further ado, I'm delighted to introduce Dr. Hung to start her journey on this impossible task. Her instructions were 20 minutes, maybe 30 minutes, TED Talk style, conceptual, and we're very grateful she was willing to take on the challenge. So thank you so much, Dr. Hung.
Thank you, Gloria. Thank you so much. It's an honor to be here, and thank you for having me. Congrats to all of you, mentors, awardees, students, clinicians, for a wonderful and productive research day so far. And I hope my 20-minute sharing and insights will help you to understand a little bit about rural America, not only the rural health research in the following 10 years, but also to understand where we are in terms of the barriers, challenges, as well as strength facing rural communities in Maryland, and collectively what we can bring together to improve and advance rural health. All right. Gloria asked me to share about the future directions in rural health research. Today, I want to, given the interest of time, I want to share more urgent issues, rural mental health research, so that we can kind of engage each other, high school mentees, undergrad mentees, graduate students, clinicians, and researchers like me. Before we get started, I want to kind of introduce our University of South Carolina Rural Health Research Center. I'm co-directing, as Gloria mentioned. Our mission is really to address the health and the social inequalities experiencing facing rural populations. We try to help them with evaluations and research. Why? Why we are doing not only statewide research, but also nationwide research, because we are trying to save those 66 million populations living in rural America. It depends on the definitions, but we all know United States are majority predominant rural lands, and a lot of them are losing hospitals, healthcare facilities. They don't have anywhere to go. When they do, they are reluctant to go because of stigma, because of trust. But then this kind of statistics, it will be a common error if you believe in me, these numbers are universal, because it depends on who you talk to. The rural classifications, the definition changes depending on whether you use HRSA, Health Services and Resources definitions for rural, urban, rurality. If you use Office of Management Business, or you're using rural, urban, community area, are you using the rural, urban, community codes? Or you're using Federal Office of Rural Health policy of classifications, or you're looking at the residential areas versus the facility areas, because it really depends. I pull out HRSA funded website. There is MI Rural website. How many have you heard of MI Rural website? You can put into your address, your county, or your census tract, and then get a report to see which definition, whether you are rural. I kind of randomly choose one Talbot County. This is one address that I put in, and we can run a report together. Now I'm showing you 4 out of 10 different rural urban definitions. If you're using Census Bureau's CBSA, the core-based statistical area, then this address, Talbot County, is a rural micropolitan. It's kind of a large rural area. If we're looking into the GIS for the census blocks, then it's actually urban area in a census. Also, Census Bureau has 2 different definitions. Say this is an urban area. In this case, if a foundation or federal agency use this definition, then people or providers living in this county or this census block would not be eligible for rural funding. The third one is the Federal Office of Rural Health Policy. It designates this county as rural. Now I'm kind of showing you different kind of definitions based on different geographic units. Next, we can kind of look at the frontier or remote area. Only 3 out of 12 federal funding agencies are using frontier and remote area, and not all the rural grants awards would put frontier and remote area as part of eligibility. It all depends on rurality. The next few several definitions, including rural-urban commuting area, that take into account population size and the travel patterns. See here, we also see it's designated rural micropolitan area. Rural-urban continuum codes designate this county as rural, as a non-metropolitan area. If you look at different kind of the most commonly used urban influence codes, we show that this is designated as an urban and metropolitan area. The last thing I want to share with you is the percentage. See here, if we are looking at the percentage for this kind of county, how many people living in the zip code tabulation areas, more than half of the residents living in this county actually were regarded as rural residents. So they are eligible. Their providers will be eligible. This is how complicated the rurality definition and classification is, and that related to the funding and resources. And that's why today I'm going to share with you a lot of evidence my team and a lot of people from the rural health research centers are doing. We kind of use different definitions based on geographic units, but bottom line, we have to really understand which communities, which census blocks, which counties we have to serve, we have to bring resources to, so that we can improve access to quality and efficient equity care. Before going in there, we have to think about which theoretical frameworks. We're all researchers or clinicians and doing a lot of theoretical framework. Which theoretical framework we want to look into? Gloria sent me the Rural Health Transformation Project proposal from Maryland, and I kind of try to align that three pillars: workforce that related to access, technology that related to access and quality. The third one is food that related to kind of social determinants of health. And I feel like the obedient access, quality, and health outcomes domain would need to be considered. So I'm going to share with you the high-level statistics that we know so far, and use the most updated data to share with you. Start with access. The access story starts before the clinic door. And you see here is from one of the rural health research centers. Rural residents rely more on the public insurance. But before that, you can see here among the children, among the children, the top panel is under 19 years old. Rural residents, even though there are cheap and Medicaid insurance that covered children, rural kids had higher uninsurance rates, 6.6% versus 5% in rural versus the urban. When we look at 19 to 64 years old, 12% uninsured rate in rural, 10.8% in urban. They are statistically significantly different. Looking at employed people, you can see rural residents really highly relied on public insurance, and mostly are Medicaid, you can see here. The reason why I didn't show the age 65 or older is because 99% of them do have which one? Medicare coverage. So rural communities actually are older and poorer. They have much higher poverty rates, and mostly people, if you look at on average, they are most likely to be non-Hispanic white populations. So now we know insurance and affordability is an issue to access healthcare for rural populations. What's even worse, even though they do have insurance, they don't have providers to go. 122 million people lived in mental health professional shortage areas. Of all these mental health professional shortage areas, over 60% are located in rural. If we only looking at rural communities, rural counties or rural communities that are designated in different HPSA, again, I just went to National Rural Health Association. We're changing these definitions, by the way. So in 2027, the whole definitions will be changed because we have to take into account not only physical providers, but also virtual providers. And I will show you why. If we're looking at rural communities, majority of them have mental health HIPSAs. And that's kind of looking at the rural percent or column percent. It's not surprising to a lot of us because some county doesn't even have one single psychiatric this design a little bit different. The first one is the psychiatric mental health nurse practitioner. 69% of rural counties do not have one single psychiatric mental health nurse practitioner versus 30% in urban counties. When we look at psychiatry, 45% versus 60% in urban. When we look at social workers or other counselors, you can see this is a pattern. The red ones are higher for rural counties, do not have one single provider for each type of the practitioners or clinicians. And they are facing this so that they don't get the specialty care they need. When we quantify, our team quantify how far you have to travel, know that it's not dichotomous only, yes or no, you have access within a county. Some county is big. Some county, when you travel from one side to another, you have to travel hours. Colorado, for example. So here I'm gonna highlight a few numbers for you. 9.4% in urban had residents, they have to travel more than 30 minutes to reach the nearest mental health facility versus 41%, about 41% of isolated rural. When we look at outpatient mental health care, 43% versus 87% for rural isolated area. Looking at inpatient care that are really providing mental health inpatient and hospitalizations, they do have inpatient wards, then 29% versus 88%. Crisis intervention, that's critical for substance use and behavioral health issues, 47%. And this is timely, but then 88% of the small rural or isolated rural as residents need to travel more than 30 minutes, have more than that. So that 88%, some of them have to travel more than 120 miles. We're looking at average. This is the issue. This is high level challenges we are seeing. What are the solutions? How can we deal with this? During public COVID, a lot of talk, even before COVID, we are really looking, we see a lot of mental health providers were trying to provide virtual services. And during COVID, a lot of people are talking about the potential, the premises of the telehealth to benefit rural healthcare, to close and mitigate this kind of access to care. Even some ambitious clinicians try to leverage telehealth or telemental services or telepsych, whichever definitions or terms you're using, to improve quality of care, to improve care continuity. So HRQ kind of started funding a lot of different kind of demonstrations and virtual care interventions. We can use virtual care to bridge lack of specialty in the rural communities. We can have provider to provider consultations. During COVID, Medicare even has this kind of coding mechanisms to allow providers to put into CPT codes and CPT modifiers so that they can get reimbursement for audio, for video, for remote patient monitoring. But it depends, for Medicaid, it depends on which states you're practicing, which states you're serving. So there are so many different mechanisms that are trying to, we're trying to evaluate right now, but the evidence is not really conclusive. We know during COVID, telehealth really increased. Here we go. Telehealth really spread quickly across the United States. Starting from pre-COVID, it's about less than 40% of mental health facilities offering telehealth. And then almost at the end of 2022, 88% of mental health facilities offering telehealth. More than 1/3 of the mental health visits actually delivered via telehealth, telemedicine. It's much higher than a lot of different clinical conditions. Guess what? 13% of mental health specialists actually only providing telehealth services without in-person services. But this is not the end of the story. Telehealth, some studies show that even for the most highly uptake telehealth providers that are on the top quartile providing telehealth services in terms of their intensity, the increase in the rural patients visits only less than 1 percentile. So 1 percentage, less like 0.88 percentage point increase. That is pretty low. We are hoping telehealth can close the gap, rural-urban gap. We're hoping this kind of resources can redirect their services so that we can improve access to care for those rural and underserved populations. But the telehealth uptake is uneven. And this is kind of disproportionately facing kind of challenging rural, underserved, and Medicaid beneficiaries. You can see here, those rural patients paid or covered by Medicaid had the lowest. They did not get to take advantage of the telehealth or telemental health services, even though this group has the highest need. And you can see all the rural communities, regardless of the insurance type, had much lower telehealth uptake compared to their urban counterparts. Why? Why are we seeing this? We know they don't have physical access. They don't have proximal access to the mental health providers. Why are we seeing so low reach for rural residents? They are suffering from mental illness. One of the reasons that our team look at is you gotta have some kind of privacy at home to use telehealth. You gotta have digital access, telecommunication devices to be able to use video, or you gotta have some kind of smartphones or tablets to be able to use telephone. Some states do not really have reimbursement scheme for for audio-only telehealth services. Only 26 states allowed the CPT codes or reimbursement code for audio-only modality. So rural communities that we found that have to travel further away compared to rural communities on average, they had much greater barriers to digital devices. They don't have computers, they don't have tablets, they don't have smartphones. Don't even mention they don't have broadband or adequate broadband to use video when providers are willing. 88% of providers are already providing this capacity, but patients were not able to. And this is one of the reasons. So speaking about future directions in research, I found out there are 3 NIH-funded mental health services. My study is one of the UO one is a consortium by the NICHD and NIH have this kind of consortium. We're also looking at the perinatal telehealth. But here, I can summarize that we are looking at a lot of studies that are pivoting from adoption to policy, equity, and quality. How can we leverage this? Where is the gap here? We need pragmatic rural studies that compare different kind of modality, audio, video, hybrid, and versus in-person care on kind of different kind of mental health diagnosis, screening, symptoms change, whether they have increased access to crisis events, whether they got the medication safety, whether they really improve care continuity. And there are so many different kind of evidence reports from HRQ that are trying to do the qualitative survey, understand quality, safety, continuity, and patient satisfactions. We see so far patient satisfactions are consistently positive among people across different kind of clinical conditions. But beyond this, a lot of studies only looking at a dichotomous telehealth, one setting versus another. We can't. We have to go beyond dichotomous nature of telehealth. We have to decide what kind of modality of which patient will be benefit or will be amenable, which conditions. Even for mental health or psychiatric services, there are so many different kind of conditions that we have to look into. How can we really optimize these pathways? What kind of risk levels, whether we can really look into different kind of outpatient, telehealth, ER, and crisis intervention settings. Which point, which timing of the care pathways we need to kind of decide this. And this is a good way because Maryland has this, one of the pillars in the rural health transformation program, try to fund 23 million for innovative care, leveraging technology. Based on literature, based on our studies, we know there are different kind of settings. They have pros and cons. And given the interest of time, I'm just showing this to you all. We want to get rid of non-ongoing care. We want to close out this kind of care fragmented nature of the mental health. Now we have technology. How can we do that? Uh-oh. Here we go. Yes, all right. Now, I think there are a few slides that kind of disappear. Amazing. So then we can kind of look into different kind of pathways. I can share the other slides with you. There are different pathways. Which setting should we initiate care? Hopefully it's outpatient setting, not in the ER, because Maryland rural community health workers wanna kind of improve efficiency, not only quality or access, but also efficiency. So let me look into. Now, the first pillar, the first priority for the rural health transformation program is about workforce and access. The second priority is about technology. So we talk about the telehealth. The third one is about eating healthy food. So when we are looking into the food, I want to kind of highlight that food is kind of a mental health infrastructure. We can turn, but then food insecurity turn this kind of choice into a systematic issue. A lot of patients, a lot of residents living in rural communities do not really have adequate access or perceived accuracy of the food. And you can see here the food insecurity rates nationally were increasing. By 2020, at the end of 2023, 13.7% of US households facing food insecurity. And this is even worse for kids, because kids tend to eat whatever the adults around them are eating, around them are buying. So this year, HRSA asked us to quantify this, and we, again, sorry about the design, in all the community, all the urban, rural, large rural, and small rural communities, you can see the percentage of the food insecure rates are about 15%, but then it's increasing by rurality. When you get more rural, your food insecurity rate rises. Among households with children, it's even larger. And I'm showing you the distribution of this my team put out last week, a few weeks last week. And you can see here, rural children are really at a very, very severe disadvantage. You can see it's kind of, if it's darker, then that means that it's higher food insecurity. So I want to propose that food insecurity is a treatment relevant exposure. And then we have to really focus on children and families. New Mexico got the HRSA demonstration grants to really bring food to the kitchen and bring patients, aging populations to the kitchen in an academic medical center. And then they relied on funding, but they are really successful. They are trying to reduce complications for people suffering from type 2 diabetes. And it's been 2 years of their evaluation report are really promising. So we can also bring those into our rural communities in Maryland. Another thing, while we're putting the maps, we're also seeing there are, again, travel burden to the nearest SNAP food stores. The distance kind of related to shopping flexibility, increasing transportation or fuel costs. Fuel cost, gas cost is crazy these days, right? You can imagine if I have to travel a lot, don't even mention if those people living in rural communities tend to have higher chronic diseases and comorbidities. So they have comorbidities for physical and mental illness. It makes them harder to really purchase healthy food regularly. If you look into this, rural communities actually rely more on the convenience store. When we look into a grocery store versus and specialty store like vegetables or meat, they have to travel very far away, and it's a regular practice. We also show communities they are seeing very high weekly food budget shortfall. What does that mean? They don't have money to buy healthy food, to buy food at all for those darker communities. And you can see in Maryland, there are a lot of darker places there. But compared to other states, Maryland is actually doing pretty good. looking into rural micropolitan counties, you can see when we look at the percentage of the rural micropolitan residents lacking grocery store within 1 mile within 10 miles for rural micropolitan residents. Maryland are doing pretty good in general, and then rural non-core as well. But then how come, even though they have proximal access to the grocery stores, they are also reporting they have insecurity in terms of access to food. And last map show you why. This is a reason because we cannot simply just say of distance is the only thing. We have to look into not only distance, but also affordability for the households. And you can see by state, it's kind of positive association. If you have to travel farther, a lot of the corresponding costs will end up having food insecurity. So where we are losing hospitals, but Maryland is doing pretty good. We are having more distribution of healthcare facilities. These are the rural healthcare facilities in Maryland, and I feel like critical access hospitals were nowhere. I think it's pretty good scale here. We have a lot of rural health clinics and federal FQC, federally qualified health centers sites in Maryland that we can leverage the primary care. We can do the integrated care along with the integrated physical and mental health care. Really have the kind of primary care moving and really helping them and then collaborating with the primary care physicians and in those rural health clinics and FQCs. So far, in Maryland, the past is not empty. We have been doing a lot in Maryland. Before 2014, a lot of focus was about who is missing care. Where are we? And then during 2014 to 2018, there were a lot of hospital reforms, especially the global budget reform. Can we, at the time, the government actually focusing on payments, focusing on the cost and efficiency. Guess what? Based on today, there are so many maps, and based on the proposal submitted to CMS for the Maryland Rural Health Transformation Program, starting from this year, I can see there are a lot of place-based transformation. Which initiative, which intervention will work? Where would we need to make this work and for whom? These are the three key terms that we have to leverage these three pillars program in the short run, immediate impacts, in the long run for the transformation funds. We got 168 millions, 0.18 millions from federal. It's not guaranteed. Based on the Washington update 2 weeks ago, every year CMS will negotiate and see the progress. And then cut, right now 50 states have the RHTP funding for at least 1 year. It's not automatic carryover. But at least for year one, we know there are a lot allocating into access, technology, and workforce. How can we deal with that? First thing, where should we focus on? Which communities we need to focus on? We have to look into different geographic areas. We have to do a care regionalization and then understand which kind of settings we have. Rural communities are very different in Maryland, in actually every state, as well as in South Carolina. Rural communities, just by definitions, are very different, right? But then rural communities have its own strength. it faces its own challenges. It faces its own restraints. But Harvard and Robert Wood Johnson Foundation actually published a very promising, encouraging report saying that rural communities are very close-knit, very resilient. So how can we really deal with this? This regional variation just show you that the nature of heterogeneity across rural communities kind of highlight the need to do a translational rural behavioral health care research. And then that brings us a future of rural health research. It's gonna be a place-based science. It's not one project that are kind of multiplying or duplicating urban research. It's not like a small urban community. Rural communities, as I said, cannot simply just 1 year pilot and then disappear. We cannot just rely on funding. We have to work together among us researchers, clinicians, facilities, and Medicaid agencies. We cannot just demonstrate and share the facility story. We have to kind of develop the rural health rural health interventions with implementation science and really understand each community has its need, has its capacity, and has its promising future. I'm very optimistic. Are you? This concludes my presentation, and I welcome any questions you may have. Thank you. And by the way, next Monday, I'm presenting rural health research centers to join the congressional briefing, talking to a few champions in the Congress to share the value of rural health research. And this is public. I can share the link to Gloria, and then you can join. It's gonna be a big deal for rural health research. Thank you.
Thank you so much. If you don't mind, we have time for a few questions, if anybody in the audience. We have one in the back, Dr. Gorelick. Sorry, if I don't bring the microphone, then the people who are on Zoom can't hear.
Well, I appreciate your talk, very informative, and I admire your optimism. So at the risk of spreading pessimism, I learned recently that the current administration has stopped doing the annual food insecurity surveys, which came up in the context of we'll never know how much the recent cuts in SNAP benefits what consequences they will have.
Yeah.
And in terms of the RHTP, I have read that the ad hoc additional funding was not enough to cover the loss to rural hospitals and health facilities made by the Medicaid cuts, one big beautiful bill, whatever it's called. So I've seen analyses that there's still a big funding gap, which is going to hurt rural health. So I wonder if you could comment on that.
Yeah, if we're talking about the funding, I'm kind of pessimistic as well. Because we are seeing Medicaid cuts, we are seeing SNAP food store cut, we're seeing a lot more hospitals that are operating in red. Financial is a big deal right now. That's why when we talk to rural healthcare facilities and administrators, we are kind of trying to do the diversified strategies. A lot more foundations and a lot of philanthropy are trying to fund underserved areas. But then how can we switch from heavy reliance of federal funding to more community resources and really leverage there? I would say resilience and strength are the part that I feel optimistic. But if we are thinking about financial performance and financial health, given this 2 weeks of all this news, given the past 2 years, we have a lot to walk and to go through. I would say I agree with you.
And if I could ask a question about, you made a comment that it's important to have privacy for telehealth care to be useful, especially for the mental health space. And I'm a child psychiatrist, and one of the memories I have early during the pandemic shutdown was talking to a child about a concern about suspected abuse or neglect. And he was on his phone, and he said, "Hold on a second." And he went to the bathroom to continue the call and close the door. Can you talk from a research perspective how we can start to collect data that's more about quality and some of these parameters that are so relevant for mental health, but for other fields as well?
Yeah, so there are a few teams. I think the quality for telehealth and virtual services kind of still in development. We don't really get to, especially for kids. We have to get IRB. It's really hard to get IRB approved when we are looking at the patient satisfaction from kids. It always needs to be approved by the caregivers. So right now, our team, and I think Brown also has one team, they are looking into claims data, try to see if telehealth, it's not about privacy though. It's trying to see if telehealth can improve guideline concordant care and improve the care continuity for not only children, but also for maternal populations. If we're really thinking about quality, there are so many domains that we have to look into. So for so far, relying on the episode level and really granular level data, this is something that we start with. And then another thing is for the survey data from adults. But for kids, it's going to be challenging. I welcome your thoughts, Gloria.
I guess related to that, there, I hear you, there's a lot of just telephone when the technology is not available. In the elderly, big
Right.
time, because they just don't use it. And certainly with kids, and I noticed young adults with autistic spectrum disorders don't do well with trying to navigate it. So it turns into telephone. The reality is ongoing. I have seen, even in our own programs, there tends to be what I would consider too high use of just telephone, and it turns into more of a chat, check-in, rather than a therapeutic service. So I wondered, has there been any research now? And so this would be higher and rural, clearly. Do we have data to compare video versus telephone on outcomes?
Yeah, actually, the AHRQ, the image that I shared, they have evidence report. They share that audio only had no significantly improved in terms of access to quality when they look into the guideline, whether these patients have improved HbA1c and or among people living with HIV, whether they are having virally suppressed outcome, there was no differences. So their conclusion is audio only is not suboptimal compared to video. But the evidence is saying we don't really see a statistical difference compared to in-person and compared to video. That's why I think there is a need for research to look at the different modality. We have to look into not only audio versus video versus in person. We have to see what kind of pathways, whether we can start with the established patients with text or video to really improve the trust between provider and patient. Then we do follow up for audio. We do follow up for in-person, then do audio. which pathways would really be optimal for which populations. For pregnant individuals, they are very different. For pregnant individuals that are having hypertensive disorder in the prenatal period, we have a very established evidence-based practice. Now, ACOT, American Congress of OB/GYN, actually are trying to tailor this kind of capacity, telehealth capacity, to design a toolkit, a standardized care for prenatal and postpartum care. We should do the same for mental health care. That's what I learned. 2 studies that are really doing the meta-analysis for audio versus in person, and if video versus in person. I don't think they really do comparison directly for audio versus video. Now, it's time for us to try to do a pragmatic clinical trial and see who will really perceive trust. Patients need to trust this kind of system. But then rural providers are not really trusting audio-only mechanisms for mental health care. They are proposing that we gotta have at least video. That's why only 26 states are reimbursing audio-only telehealth services. It's gonna be a huge hit. But our study looking at rural pregnant individuals, actually, urban individuals do not see the audio-only impacts for access, for the timing of the initiation for prenatal and postpartum. But for rural people, especially those that have to travel more than 1 hour to reach the nearest prenatal care provider, we saw a huge increase in terms of telehealth uptake. We haven't looked into the outcomes yet because the results kind of counterintuitive. But that's a very good next step for us to look into. Thank you, Joe.
Thank you so much. Thank you. Okay, last but certainly not least. So there's some high school students in the room. I don't know if some had to leave already. Is Reem here? Come on up. Is Brennan here? Brennan? She had to leave. Okay, so I'll give it to you. And how about Rima? Come on up. So we end with our true future, our high school students. We were very honored to have 3 students come and present posters at Research Day. So your gift is not a certificate or a plaque. It's something that shows you're a member of the club, and that is a gift card for Starbucks. The assignment is to invite your mentor for a coffee, green tea, whatever they're into, and sit and have a beverage with them to debrief and talk about next steps in your career, because it's certainly a bright one. So thank you so much for participating. Congratulations. All right. Thus endeth Research Day. I apologize. We didn't have the scan for credit for grand rounds. If you'd like to scan in, you can do that on your way out. And otherwise, please reach out if you have never presented a poster or you never got involved in research. Please seek out. There's lots of opportunities, non-negotiable.